Hi, my name is Emily Johnson, and I'm an FMP student at Arkansas State University. The title of my quality improvement project is Statin Therapy Use in High-Risk Patients, and at this time, I would like to acknowledge my mentor and clinical instructor, Ms. Tami Bell, APRN. Heart disease is the #1 cause of death in the United States, and coronary heart disease is the most common type according to the Centers for Disease Control and Prevention. The statin class of medications has proven to decrease the risk of cardiovascular-related deaths. Approximately for every 40 milligrams per deciliter that the LDL is reduced with statin therapy, the major risk of cardiovascular-related events is reduced by about 20 to 25%, and all-cause mortality is reduced by about 10% according to the American College of Cardiology. The current recommendation by the United States Preventive Services Task Force states, adults age 40 to 75 years with no history of cardiovascular disease, one or more risk factors, and a calculated 10-year CVD risk of 10% or greater should take a low to moderate dose statin to prevent cardiovascular-related events and decrease mortality. The purpose of this quality improvement project is to assess the rate of male and female adult patients aged 40 to 75 years old who are both eligible for and receiving statin therapy in a local clinic based on the task force recommendations for statin therapy as prevention of cardiovascular disease and related events. The objective of this study is to observe the rate of patients aged 40 to 75 years old with a cardiovascular disease risk greater than or equal to 10% of patients who receive statin therapy in a local clinic as recommended by the United States Task Force. This retrospective chart review occurred in a rural primary clinic in northeastern Arkansas. 50 charts were reviewed from January 1st, 2019 to November 18, 2019. The data was collected and simple percentages were used as a statistical analysis method. This is a picture of the American Heart Association risk calculator that was used in this study to individualize each patient's 10-year cardiovascular disease risk. It takes under consideration if the patient was a smoker, if the patient is on hypertensive treatment, the patient's blood pressure, if the patient was on a statin, if the patient has diabetes, as well as the patient's individual cholesterol readings. These charts included a randomized sample of patients aged 40 through 75 with no history of cardiovascular disease and one or more CVD risk factors, such as dyslipidemia, diabetes, hypertension, or smoking. Patients less than 40 and greater than 75 were excluded from this study. Patients with a history of coronary heart disease or cerebrovascular disease were excluded from the study as well, and the ICD codes are shown that correlate with each of these. As a result, 64% of patients that were eligible for statin therapy were on a statin drug. After reviewing patients' charts, it was found that out of 18 patients who were not on a statin, 10 of those declined. There were 3 of those 10 who stated they did not tolerate this class of medications. There were 7 patients with no known documentation of the exclusion of statin therapy in the patient's plan of care. One patient that was not on a statin drug had chronic hepatitis C with elevated liver enzymes. And one weakness of this study is I should have excluded any patient with active liver disease as it is contraindicated to prescribe a statin drug with a patient who has active liver disease. 2 of the patients who were not on a statin drug opted out to take red yeast rice. This is a percentage of statin-eligible United States adults currently taking statin therapy. As we can see, in 2011 to 2012, in the United States, there were 29.8% of patients that were eligible and taking statin therapy. This slightly increased from 2013 to 2014 to 30.3%. My clinic's percentage of 64% is significantly higher than the United States, but we do have to take under consideration that this comparison used the 7.5% as the minimum risk factor to prescribe statin therapy, and for my project, I used the United States Task Force of 10% as the minimum risk factor to prescribe statin therapy. Although my clinic's statin therapy percentage is probably higher than average, the results of this study can be used to recognize a need for this clinic to focus on techniques to increase statin therapy compliance. The results of this study showed that most patients refuse a statin therapy due to intolerable side effects, and 55.56% of patients declined a statin due to these intolerable side effects. And as many studies have shown, intolerable side effects is one barrier to prescribing statin therapy and decreasing cardiovascular-related events and deaths. My action plan to decrease barriers to statin therapy compliance include to identify each patient individual issue and work with them to develop a plan of care that works best for them. We also need to utilize statin intolerance calculators as well as the AHA risk calculator. We need to reduce the dose or change medications. Some statin drugs will stay in the system longer than others, so if we change the statin drug, we might decrease their symptoms, as well as if the patient can take the medication at least once every other day or once weekly, they will still see a benefit from that medication. We need to simplify the patient's medication list as much as possible. We need to remind patients to take their medications, and we need to show them the laboratory results and that what they're doing and their hard work is paying off. We also need to take each individual's educational background in consideration when trying to attempt to teach these patients. These are my references, and that concludes my quality improvement project. Thank you very much.